welcome you all to the TEPHI, Texas Epidemic Public Health Institute Grand Rounds series. We're going to be talking about severe hepatitis in children today, as you can see from the title slide. I wanted to tell you a few housekeeping items. If you have questions, you can put them in the Q&A and we'll ask those questions after the presentation. Also, this will be recorded and on the TEPHI website in a couple of days. You will get a notice, an email notice sent that it's up and ready to view. And I wanted to tell you about our upcoming grand rounds in November. Dr. Jacqueline Minter, who is the director of the Fort Bend County Health Department, will be speaking on their experiences during the COVID pandemic. In January, Dr. Anthony Moresso from Baylor College of Medicine will be talking about wastewater surveillance that we've been hearing so much about. And then in March, just in time for mosquito season, Chris Frederigill, who's the director of Mosquito and Vector Control Division at Harris County Public Health, will be speaking on vector-borne diseases. If anybody has suggestions for other topics you'd like to hear about, please let me know. I am going to put my email in the chat, and I probably should have said my name, huh? I'm Kathy Troisi. I'm here on the faculty at UT School of Public Health and involved with TEPHI. So let me, oh, I don't think you can see that.
Do you need me to let you share screen?
No, I will think of a better way to get my email out there. Or just email TEPHI. It doesn't have to be me. And you can see from the TEPHI slide our email address. And I will put, I can't put it in the chat because it says only hosts and panelists see it. Okay, so let me introduce our speakers today. Dr. Elizabeth Moulton, MD, PhD, is an assistant professor of pediatrics in transplant infectious diseases at Baylor College of Medicine and Texas Children's Hospital. She began her research career by studying the role of the complement system in pox viral infection during her PhD studies, and she continues to look at the interplay between the immune system and viral pathogens in pediatric patients. She has specific interests in how best to diagnose, treat, and prevent infections in these transplant recipients. And she spends her clinical time caring for solid organ transplant candidates and recipients at TCH, which is the largest pediatric solid organ transplant center in the country with a focus on pediatric liver and lung transplant. Our co-speaker is Dr. Anna Banc-Husu, who is an assistant professor of pediatrics within the section of gastroenterology, hepatology, and nutrition in the Department of Pediatrics at Baylor College of Medicine. And she's a transplant hepatologist at TCH. She's a clinician scientist with research interests in the critical care of children with liver disease, including acute liver failure and acute on chronic liver failure. Her research focuses on the role of the immune system in the development of acute on chronic liver failure and how to better improve the multidisciplinary management of children in the intensive care unit to improve patient outcomes before and after liver transplantation. So as I mentioned, and you can see on the screen, they are going to be talking today about the role of adenovirus in severe hepatitis in children. So thank you both for being here.
Thank you for having us. So as you can see, we have just some disclosures of our research funding, and I'll let Dr. Banc-Husu start.
Perfect. So we thought that we would first start today's talk on a brief introduction to hepatitis. So when we use the term hepatitis, we're referring to an inflammatory injury of the liver, and it's really regardless of the cause. And what I've included here are pictures of a normal liver on your left-hand side, where you see your nice, pretty pink liver cells. And on the right-hand side, we're seeing inflammation, inflammatory cells, white blood cells that are infiltrating the liver, the liver parenchyma, the liver cells, the portal tracts, and that is what we term hepatitis. Next slide. When we think about hepatitis in children, there's actually a lot of different causes of hepatitis, and we like to group them by etiologies. On one side, you have infections, and infections with viruses that target liver cells. So, things that we commonly think about, hepatitis A, B, C, D, E. You also have infections that are systemic that can have manifestations as hepatitis. And these include viruses like adenovirus, which we'll talk more about later, but also things such as EBV, which causes mononucleosis, HSV, and a list of other viruses. There can also be non-viral infectious diseases that can lead to hepatitis, as well as other metabolic and autoimmune and inflammatory conditions. And one of the things that I just wanted to highlight under the autoimmune inflammatory conditions is this condition, hemophagocytic lymphohistiocytosis, or HLH. And that is something that is on the spectrum of inflammation that can lead to hepatitis, liver damage, and even liver failure. Next slide. When we think about how children with hepatitis present, there really is a spectrum. Some children are completely asymptomatic, and hepatitis is identified on routine lab work that is done by the pediatrician. Some may have mild symptoms such as jaundice, abdominal pain, fatigue, or malaise, whereas some can present severe with fulminant liver failure. Next slide. And when we think about fulminant liver failure or acute liver failure, it does have specific criteria. It requires children to have acute onset of presentation without any evidence of chronic liver disease. There's evidence of severe liver injury when checking labs, and these patients have severe coagulopathy that is not corrected by vitamin K, which we identify by a lab test called the INR. Next slide. And when we think about the etiologies of liver failure, this study from the Pediatric Acute Liver Failure Study Group looked at over 1,000 children with acute liver failure, and about 8% of those with liver failure developed it from a viral cause. Next slide. Next slide. Thanks. And oops, go back one, please. Thank you. And I think what's interesting when we think about viral etiologies of acute liver failure, we can see that it's really a much larger proportion in neonates. So in children who present with liver failure in the first 90 days, there's a much larger proportion from viral etiologies than in children who present at an older age with liver failure. Next slide. And when we think about liver failure in children, there's really, liver failure can have a varying course. Many children will present with a prodrome and then can potentially have progression of their disease. Some patients can recover, some patients may die. And the interesting part, and this is where we as pediatric hepatologists and our transplant team come into play, is transplant can really occur at any point during a clinical course for a patient. And it will interrupt the natural history that that patient was going to undergo. Next slide. And lastly, I like this slide because it really highlights one of the important roles that we need to do in identifying why a child has liver failure. Because when we look at different causes of liver failure, the outcome as to whether the patient requires transplant, has spontaneous recovery, or dies is different depending on the etiology. And we look at viral causes of liver failure, we can see that a fair proportion do fairly well, but compared to other etiologies, there's a fairly high amount of patients who end up dying. And this is really, we see this the most in the neonates who develop liver failure from viral infections such as HSV and enterovirus. Next slide.
So now I'll talk a little bit about some cases and how this all evolved. Our first case was a previously healthy toddler who presented with abdominal pain, vomiting, and jaundice. He had initially very severe acute hepatitis that pretty quickly progressed to acute liver failure. He was initially treated with IV steroids due to concern for autoimmune hepatitis. Adenovirus was detected and he was treated with cidofovir without much improvement. And there was concern about viral infection, possibly precluding transplant. So he was transferred to Texas Children's Hospital to help support him while we tried to hope that he would clear his virus. When he arrived, his adenovirus testing here was negative and he underwent successful liver transplant. Then 2 weeks later, a previously healthy preschooler presented with fever, fatigue, vomiting, and jaundice, and very quickly developed acute liver failure. This child also had adenovirus detected and it went up during the hospitalization to greater than 100,000 copies per ml. And it was treated with cidofovir, which is an antiviral that is sometimes used, although not approved for adenovirus, and did have some improvement in the adenovirus levels. Additionally, this child was diagnosed with hemophagocytic lymphohistiocytosis, which I will call HLH from now on, and was transferred, which is another concern, not an ideal situation for a liver transplant. And so it was transferred for Texas Children's Hospital for some of the wonderful support that our ICU is able to do. Here again, the adenovirus tested negative and the child underwent successful liver transplant. So giving these two presentations, we were actually fairly concerned that something was going on, especially when the referring hepatologist said, oh, I have 3 other cases that also have hepatitis and adenovirus in a month. And so these cases had a number of the factors that we make us think about outbreak investigations. So they both had very severe clinical presentations. It's not normal to have this number of acute liver failures, especially from a small geographic region or a small period of time, or even cases of hepatitis in a month. So increased frequency of diagnosis. These children were actually previously healthy, and I'll tell you a bit more about how usually adenovirus hepatitis occurs in immunocompromised individuals. And then we had the clustering of these cases both in time and space geographically. And so we were fairly concerned about the investigation. We had a number of hypotheses upon seeing these 2 children about what could be going on. Initially, we were fairly concerned that perhaps these kids had an underlying immunodeficiency that just hadn't been recognized, and that's why they were so sick and had acute liver failure at their age. We also worried about whether there could be a new or a more virulent strain of adenovirus in the community that was causing this cluster. Adenoviruses can actually cause a latent infection, although the mechanisms of that is not as well elucidated as with other herpes viruses. But whether or not, we pondered whether the virus could just be there and they had acute liver failure for another reason, and it just reactivated in the setting of the children being so ill. And we also thought a lot about, is the population different because of the social distancing that had occurred in response to the COVID pandemic? And perhaps we have more kids who are susceptible to viruses because the usual viral cycles had been disrupted. And perhaps that, not having the adenovirus infection early in life has created a more vulnerable population, or they have an abnormal response. We considered whether this could be something similar to MISC, the inflammatory syndrome after COVID, because our patients had had exposures to COVID, although they had no evidence of prior infection. And so that was considered. And we wondered whether there could be some synergy in these individuals between other infections like EBV or rhinovirus that we had detected in adenovirus that was leading to this very severe presentation. And finally, based on the fact that we had these differences in testing between the 2 centers, we wondered whether or not this is something that had been going on for a while, and perhaps because we use a different specimen to measure adenovirus. We typically use plasma, whereas the referring hospital uses whole blood. Perhaps these cases had been occurring all along and we just hadn't recognized them because we weren't testing the right sample. And so speaking to that last point a little bit, when we went back and had our lab actually try to sort this out, and they tested whole blood samples on our patients, they actually tested positive on whole blood, suggesting that whole blood is the sample of choice. And this isn't something that is commonly known in the literature. We went to the literature to look to understand the differences in the testing we were seeing. And there's one small study out of St. Jude's where they look at the correlation between whole blood and plasma for testing. And the correlation coefficient is 0.98, and you're not going to see a prettier correlation coefficient in the literature out there for the patients who had positive samples in both. But interestingly, and this is again a small study, there was one patient who was positive only in whole blood, and the level was actually 30,000, so a decently high level, which made us wonder whether or not perhaps this is a strain-specific phenomena. It's interesting that it happened in 2 patients, and we've subsequently seen it happen in others. And so again, with the concerns about strains, we'll talk a little, or types, I'll talk a little more about that. So adenovirus is a family of double-stranded, non-enveloped DNA viruses that are very hardy and can persist in the environment. And as I mentioned, they can remain in the body and reactivate. And there's certain species C mostly is associated with hepatitis and disseminated disease. And so I fully expected when they sent the samples to the CDC that we were going to end up with one of these viruses as the cause, and perhaps maybe a new specific type of strain of it. But we were shocked, actually, when the typing results came back as adenovirus 41. So that's in the species F group. And these viruses are typically cause gastroenteritis, and they are not known to cause hepatitis of any kind, and certainly not in healthy children. And so that was kind of a big surprise for us. And so the CDC released this health advisory notice in April after we got these results back, and then also heard about what was occurring in Europe around the same time. And so of the 9 patients that were originally identified in the cluster, they sent them for typing, and they were able to sequence 5 of them. The others they couldn't sequence because the viral load was too low. There wasn't enough DNA. And all 5 of them had actually sequenced as adenovirus type 41. And then this is also where we published our observation about the fact that the plasma samples were negative in these patients, suggesting that whole blood was perhaps a more sensitive mechanism for detecting adenovirus. Since then, the CDC has provided recommendations for testing for acute hepatitis cases, which include testing for adenovirus using a nucleic acid amplification test like PCR from a variety of specimens. Certainly a blood specimen, ideally whole blood is preferred, just given this increased sensitivity, but also checking for adenovirus in a respiratory sample, a stool sample, and if the patient's having a liver biopsy, that can be tested by PCR as well. Since additional data has come out from Europe, they're all now also requesting SARS-CoV-2 serology as well as nucleic acid amplification testing to be conducted on patients as well to help with understanding this outbreak. I will now switch and tell you a little bit about what we knew about adenovirus hepatitis last fall, about a year ago, before these cases occurred. So this is a series where they looked at all of the fulminant cases of hepatitis in the literature, and they had to have adenovirus detected in the liver to be included. I'll draw your attention to a few points. Almost 2/3 of them are a pediatric population, but most importantly, 98% of these patients are immunocompromised, and we would consider neonates to be functionally immunocompromised when it comes to virus. So almost everyone has an immunocompromising condition. And these patients presented differently than our patients. They had fever in almost all of them. And jaundice occurred in a minority of cases. When they looked under the microscope in these cases, necrosis was the most common feature, which we did see in our patients, but 70% of them had intranuclear inclusions, and smudge cells, which I'll show you pictures of in a little bit, occurred in 1/5 of patients. And the other key factor to note is that the survival was only 27% out of these cases. Now, again, they're presenting with fulminant hepatic failure, and most of them are immunocompromised. And so this is actually not too surprising, but this is what was out there. In a different series done by pathology group, you can look and see that all of these 12 cases, they all have some amount of necrosis. Interestingly, there's not a lot of neutrophils, only a few lymphocytes in a few patients, not a ton of inflammation. It's really necrosis is the hallmark of how these patients present. Almost everyone has viral inclusions, and most of them are testing positive for immunohistochemistry, which is different than what we saw in our cases. And here's just a picture. You can get inflammation with the prior adenovirus hepatitis, and you can see kind of spotty necrosis. And then these large nuclei here are an example of smudge cells, which are pathognomonic for adenovirus. Here I have some of the pathology shown for our patients, and you can see in patient 1, there's some inflammation along the interface, which is a characteristic of autoimmune hepatitis. In case 2, there's inflammation in the portal tracts as well as the lobules. and they stained for CD68, which is a marker for macrophages, which are involved in HLH. So this is consistent with HLH. And then I'll just draw your attention to, you can see, in the staining, looking at T cells, which is CD3 and CD8, you have an abundance of CD8 positive T cells in the liver in these cases. Is there anything that you would like to add, Dr. Banc-Husu?
Nope, I think you summarized it perfectly. And I think just to highlight, from the previous case, we didn't see, these patients did have areas of necrosis, but not massive spotty necrosis as classic for adenovirus, and absence of smudge cells.
I should also mention that the immunohistochemistry for adenovirus was negative. Electron microscopy looking for viral particles was negative. But the PCRs from their liver tissue did indeed detect adenovirus. So very interesting. So now to talk a little bit more about pediatric hepatitis of unknown etiology and adenovirus-associated hepatitis, as our cases were. So the case definition varies depending on which locality, but they all share in common that cases have an AST or an ALT greater than 500. They don't have any of the routine hepatitis viruses that Dr. Banc-Husu mentioned, and have an unknown etiology for their condition. And then the CDC and WHO started collecting cases in October, whereas the UK started a bit later because their outbreak occurred more in January and the subsequent months of the year. And then the age varies depending on which definition as well. So that contributes to some differing numbers across different sources. So our patients were included in this first cluster that was published recently in the New England Journal, detailing the US first initial cluster that was identified. So they looked back over the period of October to February and found 15 patients who had hepatitis. Of the 6 who had hepatitis with a known cause, 5 of whom were tested for adenovirus, and they were all negative. Of the 9 with unknown causes, 8 of them actually had tested positive for adenovirus. And then they added to it another patient who was seen in an outside hospital but followed up with them, who also had adenovirus, giving them the 9 patients that they had followed. And so those are the 9 that were described in the MMWR article. And so when they took these patient samples of them that they were able to sequence, they did phylogenetic analysis of the samples. And interestingly, the 2 patients who had liver failure and required transplant are actually clustered here pretty close to each other, which certainly raised our concern about whether there could be a new strain. And then the other patients that they had and were sequenced are in blue and are sort of distributed throughout the tree and have a couple of things. So there's certainly multiple strains. They're not all exactly one strain, which is important to note. And they do have some similarity to prior strains. So this was sort of a surprise and interesting. The CDC next looked at whether or not we were seeing more cases of hepatitis in the ER, whether this was truly a surge or whether this was consistent with kind of our background rate. And based on their analysis, looking at ICD-10 codes for both young children, 0 to 4, and then the older 5 to 12-year-olds, they do not see an increase in hepatitis cases overall. They also looked at hepatitis-associated hospitalizations over time, as well as transplant for basically acute liver failure. And they don't see a significant spike over time, which was interesting. What they did see, which is sort of important to think about what is going on epidemiologically in the whole viral milieu that everyone's existing in, they did see an increase in adenovirus 40 and 41 infections. And so traditionally, as I mentioned, this causes gastroenteritis. So we usually detect it in stool. It's actually not very easy to culture this virus, and it's usually detected by a stool PCR. And so when they looked at LabCorp in young children, they do see an increased rate of adenovirus 40 and 41 positivity occurring over the time that we're seeing these cases of hepatitis. This is in contrast to some of the data that was coming out of the UK. So the UK really recognized in early in this year, this kind of increase in hepatitis cases. And of the 44 cases that they looked at, 14 weren't tested for adenovirus, but the 30 that were, 27 of them tested positive, which is a really high rate. And of those, 22 were, survived and recovered, whereas 5 required liver transplant. And of the 3 that tested negative for adenovirus, all of them survived without transplant. But to just give some context about what was happening, this chart here shows you the annual number of hospital admissions over, in blue, and then the proportion for the first 4 months of the year, January to April, in dark blue, and then the transplants per year is in yellow. And you can see in 2022, they had 13 admissions in just 1/3 of the year, which is way more than they'd had in the prior whole year, and had done more transplants, twice as many transplants as they had done in the whole year. And so something was clearly up. So they had a larger population. So I think that this is kind of nice to see the clinical symptoms of the patients that had presented. Interestingly, jaundice is the most common symptom that we're seeing in these patients, in 93%. And that's similar to what we saw in our population, that really the kids were brought in because their skin turned yellow or their eyes turned yellow. They also often have symptoms of vomiting, diarrhea, pale stools, which can occur with a cholestatic hepatitis, which is what the patients have, and abdominal pain. Interestingly, these are all symptoms, other than the jaundice, of gastroenteritis. So vomiting, diarrhea, abdominal pain, all would fit with an adenovirus 41. Fever or pyrexia, really is occurring in the minority of cases. So this is not generally a febrile illness. And then I think very importantly, they used whole blood adenovirus PCR. And doing that, they are detecting it in 93% of their cases. And as Dr. Banc-Husu pointed out, this is a very, there are a lot of different things that can cause hepatitis in children. And so to see this detected in 93% of them is somewhat surprising. And really, in my mind, suggests that this is contributing to it. But additionally, they detected SARS-CoV-2 positivity in about 1/3 of patients. And this was in the early part of the year. So this was during the Omicron surge. So we were seeing tons of SARS-CoV-2 positivity in patients as well. And about 40% of patients had serologic evidence of a prior COVID infection. And then we see other viruses that we see commonly in kids. So enterovirus or rhinovirus, common upper respiratory viruses. We see HHV6 as well, and some other viral etiologies. But again, we're testing, in large part, this is a young population, and so they do have co-infections. So just to provide some updated numbers from the CDC, in the middle of August was the last number. We had 358 cases in the United States from 43 states and countries. Again, this is a very broad definition, so it's going to encompass a lot of people. But the median age is 2 years old. 6% of them have needed transplant and 4% have died. So of the 13 cases, the median age was 1 year. So it seems like perhaps maybe deaths are a little bit skewed, although the data is rarely very limited. It seems like 4 of the patients who died had received a liver transplant, and that certainly can be fraught with complications. And 5 of them had underlying conditions, including 2 were immunocompromised. 84% of patients in this population had adenovirus testing on some specimen. And of those, 45% of them had adenovirus detected. They've been able to do typing on, I think, a little over 20 samples. Of the typing that they've done, 13 of them have typed as adenovirus 41. And then the remaining ones are kind of, adenovirus 40 in some ways is very similar to 41. And then the rest are more of the more traditional species C viruses that cause hepatitis and systemic disseminated adenovirus infections. The WHO has reported over 1,000 cases of hepatitis occurring in more than 35 countries. They take cases up to 16 years old, but over 75% of them are under 6 years. So this, I think we're really all seeing the same thing across the spectrum, which is this is conditioned in very young children. And their numbers are similar, with about 5% having required liver transplant and about 2% dying. When the WHO looked at the European region, when they looked at patients who were either adenovirus positive compared to their adenovirus negative counterparts, they do see an increased risk for ICU admission and also for transplant in patients who are adenovirus positive. And this is in contrast to being SARS-CoV-2 PCR positive, where there's not a statistically significant difference between them. Dialing in a little bit more on the UK, where the bulk of the cases in Europe have happened and a lot of the data has come out of, when they look, they're finding adenovirus in 68% of cases. They're finding SARS-CoV-2 in more like 10% of cases overall. And then none of the other pathogens are seen in a majority of patients. There was a lot of concern, especially during the initial period of Omicron, that they were seeing SARS-CoV-2 in a substantial proportion of patients. And again, we just went through this whole multi-system inflammatory syndrome of children process as a post-COVID infection, a post-COVID entity about whether all of this was related to COVID. And when they go back and look at positive tests in the prior, more than 14 days prior to admission, and the hepatitis cases in blue, or all admissions in green, or positive tests basically in the weeks prior to admission, they don't see any significant difference here. When they went back and looked at cases and control sera that they had in the lab, they see similar levels of SARS-CoV-2 antibody positivity between cases and controls. They looked at patients who had required liver transplants in England. Of those, 9 out of 10 tested positive for adenovirus in the blood sample. And there's in the data, a lot of grouping of whole blood and plasma, which I think confuses things to some extent. But they do note that the case who was negative was tested on a serum or plasma sample. And then of the 6 cases that they were able to successfully subtype of people who needed liver transplant in this group, they all typed as adenovirus 41F. They've done a fair amount of typing on different samples. So blood samples here, they've typed, about half of them. They're able to type, and in 95% of them, they've typed as adenovirus 41. In this figure, the 4 liver samples that they were able to type were all 41, whereas the respiratory samples and the fecal samples have actually been other types of adenovirus, which is somewhat interesting. And then they did some genomic sequencing of some of the adenoviruses. The 3 cases are in red, and they're a little bit hard to see, but there are 2 right here, if you can see the mouse, and 1 right here. And then the blue are recent sequences from 2022, sort of scattered throughout. So there's some clustering, but there's also some different sequences as well. So it's suggesting that it's not all perhaps one strain. They did metagenomic sequencing, where they tried to look for DNA for any pathogens, and they sequenced blood, serum, and liver samples. 1 sample had had no pathogens, and then 9 out of the 10 samples, which is 8 people, they actually detected adeno-associated virus in. They detected a human herpes virus 6 in 3 of the samples. And they were able to confirm HHV6 in several. And then they detected torctenovirus, which is just a virus that is sort of an endogenous virus that you can see at low level, and astrovirus in 1. But given the adeno-associated virus, and just to tell you a little bit about that. So adeno-associated virus is a small single-stranded DNA virus in the Dependovirus genus, which is in sort of the parvovirus family. But what's interesting about it is it can't replicate on its own. It needs a helper virus. And that's usually adenovirus or herpes virus like HHV6 to provide some of the machinery that it needs to complete its viral life cycle. And so it always needs a helper virus to really replicate. There's not much in the literature about it causing hepatitis or any real problems. And these have actually been used as gene vectors for gene therapy. And so there's not a whole lot out there. But when this group went back and looked, they detected adeno-associated virus in 9 out of 9 plasma samples and 4 out of 4 liver samples in hepatitis patients. And they went back, importantly, and found some controls. So looking at age-math healthy controls, they don't detect it in them. They looked at 12 children who had adenovirus infection and normal liver function, and they don't see it. And then they had 33 children who had hepatitis of a different etiology, and they're not detecting it as well, suggesting that, because sometimes when we do see sometimes when you injure the liver that usually I think of it more about herpes viruses, that you can detect low level of herpes virus reactivation in the setting of acute illness, but they're not seeing it here. They just also detected adenovirus, either species C or F, in 6 out of 9 cases using a variety of sample types, 3 out of 4 liver biopsies. And then the human herpes virus 6, which causes roseola, a febrile illness in infants, in 3 of 9 cases and 2 out of 4 liver biopsies. So here they looked at the actual levels of the adeno-associated virus, and they walk through, this is just like your water control, then your healthy patients, your patients with adenovirus but normal liver enzymes, and then patients with elevated liver enzymes and non-adenovirus. And the y-axis here is your cycle threshold value, which is sort of popular in the SARS-CoV-2 as sort of a proxy for virus level. The higher the number, the less virus is around, because it takes more cycles for the PCR reaction to replicate to reach the threshold to be positive. So a lower number actually means more virus. And so you can see here, these cases all have a lower cycle threshold, suggesting more virus compared to other patients. And then they also looked at adenovirus, and I think for full completion, it's good to include this, looking at adenovirus 41. And they do see, they were using plasma here. So they're not seeing a lot of it in the plasma in the cases, but I do wonder if it's related to the specimen type. And they do see a little bit, although these are pretty low levels of virus in them. And then a different group, and there may be some overlap. It's not clear in the literature which patients are possibly duplicated in different publications. But when they look at adeno-associated virus, they have a cycle threshold in the mid-20s, whereas you don't detect it in healthy people. They're not detecting it in patients with adenovirus in other sites or in the blood with a normal ALT or other sites. They do detect a little bit in some patients with a normal ALT and a normal bit in the blood. And then patients who are just ill and have elevated ALT, they aren't detecting it. So suggesting that not everyone who has hepatitis or liver injury, has this virus in their blood, which is really the main question. And one of the things that we honestly didn't know at the beginning was, do you see this adenovirus or an adeno-associated virus in everyone who has hepatitis if you look for it? And it doesn't seem like you do. They did some sequencing similar to what they had done before of the adeno-associated virus, and the cases are all in red. And you can see that there certainly is some clustering, but there's some distribution as well. And so it doesn't necessarily appear that it is all, one, clade or a new clade of adeno-associated virus that is associated with this, which is interesting. And then they did a case control study, which I actually think is quite nice, in the UK, where they matched cases based on age, month, and then region of the country with up to 4 controls per case. So they had 74 cases and 225 controls. And their adjusted odd ratio for cases having adenovirus compared to controls was 35, with a confidence interval of 15 to 81, which is really very large. And I think would fit consistently with what we've seen in our small case series, that in these patients, we're seeing adenovirus in a large proportion, much larger than what we have seen previously or appreciated, although some of it may be biased by increased detection by using whole blood assays or PCR assays to fully investigate for adenovirus. And importantly, these cases did not have a higher likelihood of concomitant or recent infection with SARS-CoV-2 compared to the controls. So that leaves us with, what is the role of adenovirus? Which is an important question, and I'm not sure we have exactly the complete answer or information, but we'll go back to kind of the hypotheses slide that you saw earlier. So I think, with our investigation to our patients and what's really coming out in the literature, this does not appear to be an underlying immunodeficiency. These are really healthy children who are having this condition. As far as a new strain, it seems to be pretty associated with adenovirus 41, but it's not necessarily a new strain, because some of the strains are similar to strains that have historically been around, although I'm still very interested, and hopefully we'll get full sequencing to really dive into the genome to see if there's anything perhaps different about the virus strains that we're seeing now that might explain some of this pathology that is associated with it. It's hard to know what the impact of having an increased susceptible population is, but we certainly do have young children that were sheltered during social distancing and didn't get maybe adenovirus when they were an infant, and they're getting it when they're 2 or 3. And what the impact is on the immune system and the response, we don't really know, but it certainly does, you know, that is the timing in which this is happening. So it's something that we are still considering. You know, whether or not this is all just an abnormal immune response, possibly independent of, you know, adenovirus. Did they not get regular RSV or flu or other things that would otherwise prime their immune system to react in a normal way to adenovirus? And so perhaps they have an abnormal response when they come across this. I think really it's really very interesting to ponder whether or not there could be some synergy between adenovirus and this adeno-associated virus that's being identified. Certainly not anything that's published or described previously, but, you know, is there some, you know, are these coexisting in a way that is causing increased immune activation and leading to these consequences? And I think, as you know, the adeno-associated virus has really been looked at in a very, I would say, minority of these cases, but we will see over time and whether or not we detect that. And we have had a couple patients who have had this detected on sort of whole genome of metagenomic sequencing. And so certainly, it's certainly a plausible, you know, hypothesis. And I think one of the leading ones, just given that, you know, not everyone has adeno-associated virus, and they don't obviously all have adeno-associated virus too. So it's certainly worthy of further investigation. I'm sure some component of this is probably increased testing and recognition. And that may be related to, you know, now that people, the alerts have come out and people are testing whole blood or liver tissue, that they're detecting it more. And then I think very importantly, just given that we haven't seen the virus itself in the liver, whether much of this is related to a pathogenic immune response to adenovirus 41 infection. And I'll let Dr. Banc-Husu talk more. You're muted.
Thank you. You would think after 2 years of doing this, I would remember. So, you know, as I mentioned previously, especially in patients with severe hepatitis and acute liver failure, we always think about HLH. And outside of that, when we think about the immune system in patients, there's really a spectrum of inflammation. And on one side, you have inflammation that's triggered by infection, by sepsis, by the environment. Whereas on the other side, which is where HLH and these systemic inflammatory syndromes such as macrophage activation syndrome, et cetera, fall, it's really pathologic inflammation that's driven by the host that's leading to the systemic inflammation. And depending on where you fall, you can see at the bottom, your approach to treating these patients is different. And very early on, when the initial data from the PALF study group came out, we found that around 40% of children, especially children between the age of 2 and 6, did not have an identified cause of liver failure. And this group of children was very interesting because many of them either ended up to transplant or ended up dying. And a lot of research in the most recent years has focused on this group of children with indeterminate PALF. Next slide, or next mouse click. And really, we think that indeterminate PALF really lies on the spectrum of pathologic immune activation. Next slide. Many studies within the last couple of years have focused on these children with indeterminate PALF or IPALF. And interesting, what they have found is that these children do have evidence that their immune system is revved up, both in the periphery when they look at markers of systemic immune activation, similar to the markers that we see in HLH, but also when they're looking at liver biopsy specimens. And what you can see here in panel A are 6 different patients with indeterminate PALF. And these patients had their liver biopsies stained for CD8 positive T cells. And we can see in all 6 cases, they have very dense, intense staining. Panel B is showing you liver cells and liver specimens from 6 different cases of PALF where the cause of PALF was identified. So for example, viral, autoimmune hepatitis, Tylenol, etc. And you can see the striking difference in the fact that in panel B, there's really minimal CD8 positivity in this liver. So the thought and the hypothesis is that, especially in children with indeterminate PALF, overactive immune system and inflammation in the liver is what's actually driving the liver damage leading to liver failure. And what's interesting is that this is similar to what we saw in our patients when we looked at their liver biopsy. We didn't see the classic findings of adenovirus hepatitis that Dr. Moulton so nicely outlined, yet we're seeing inflammation. And in one patient who developed HLH, you even saw the extreme spectrum of inflammation in the liver. So I think there's more that we need to learn about the role of adenovirus in hepatitis, but there might be some role that it's triggering inflammation. That's the primary driver of the damage that we're seeing in these patients.
So in summary, I just want to highlight that as the investigations continue into these cases of unknown hepatitis, the definition of patients who are included is very broad. And so it's probably going to have a heterogeneous population. And so I wouldn't expect to see adenovirus or any etiology be in 100% of the cases, just because there's so many different things that can cause injury to the liver. In the case series that have looked in whole blood or liver PCR, they are detecting adenovirus at a pretty high proportion. And unfortunately, in a lot of the data, they're grouping whole blood with plasma and serum. And so when you do that, you lose some of your sensitivity given the differences that we've seen in the testing. Adenovirus 41 seems to be most associated with these cases based on the typing, although there are seeing other different strains as well. But before this was identified, adenovirus did indeed cause hepatitis as well. So seeing other strains causing hepatitis isn't too surprising. It's interesting that they've seen this adeno-associated virus at a fairly high frequency in a small case series, and certainly worthy of further investigation and looking at a larger cohort to understand the mechanism of it. And then there has been very minimal evidence of adenovirus infection directly in the hepatocytes, in that we haven't seen viral inclusions. The immunohistochemistry is negative, including that done at the CDC, where we know that their antibody does in fact detect adenovirus 41, and we aren't seeing the virus on electron microscopy, suggesting that perhaps what we're really seeing is more consequence of the adenovirus perhaps triggering this pathologic significant inflammation that's leading to acute liver failure and hepatitis in these cases. And with that, we would be delighted to take any questions.
Thank you so much. That was a terrific overview. And we do have a few questions. Find them. Okay. This is from Julia Hankins. Since there was no adenovirus seen via IHC, but it was positive via PCR, could this PCR positive come from blood present in the liver biopsy and not the liver tissue itself?
That is a fantastic question, and that's one that we have struggled with over the years. So I will say that not every time you have a virus positive in the blood, when you biopsy the liver, you don't always detect it. But you certainly can, because there's blood in the tissue that is collected. And so we do wonder if that is the cause of it. In our patients who we presented here, we actually sent their explants to the CDC as part of this investigation, and they did detect adenovirus species F, which would include adenovirus 41 in the explants. And that was at a time that the viremia had either cleared or was very low. So there may be some virus in the liver itself. And some things I've pondered is whether or not it was in the liver, but didn't necessarily cause any damage. And it's really the immune response to it that we're seeing, because you know, these patients can often be sick for, some of them, weeks before they present. You know, some of them present very quickly, but some have a more protracted, you know, I had gastroenteritis a month ago, got better, but not all the way better. And then, you know, weeks later got jaundiced and then presented. So that is something certainly that we have pondered. And since traditionally people have not been looking for adenovirus 41 in liver or other tissues, we initially had some concerns about whether, you know, the antibodies were working or those sorts of things. But as we investigate this more, we'll learn more about that and hopefully have tools to make sure that we have identified it. But thus far, we haven't seen a lot of evidence for it in the liver.
Thank you. And a question from Leslie Taylor. Is there any association between these increased virus levels and hepatitis caused by chronic liver issues, such as choledochal cysts, or this virus surviving in stagnated bile for other reasons that causes an increase in hepatitis cases?
So I can go ahead and answer that question, Dr. Moulton, if you'd like.
Yes, please.
So I think that's a really, really thought-provoking question. I will say that at least from the data that the CDC is collecting, and as a hepatologist, when you see a patient with elevated liver enzymes, our first job is to determine, is this an acute process or is this chronic, from a chronic liver disease? And I know you mentioned choledochal cysts. Those are, you know, something that we always think about, oftentimes present more in infants and more with cholestasis and jaundice. But I can't say that we've seen, at least clinically, an association with increased number of chronic liver diseases that we've diagnosed in the setting of this outbreak. I don't know if that answers your question directly, but you know, when many viruses that cause hepatitis are short-lived and lead to complete resolution and not long-standing chronic liver disease, the hepatotropic viruses A through E, especially specifically B and C, can lead to chronic liver disease. But you know, at least from our experience since this outbreak started over the last year, I can't say that we have seen an increase in chronic liver diseases presenting, at least here at Texas Children's.
And I had a question for you. I didn't see an epi curve. Our cases, maybe it's hard to determine because I'm assuming this is not a reportable disease, so it's hard to find how many are happening. But if the reason that you're seeing this is because these young children have been isolated during the early days of the pandemic and not exposed to other viruses, as we stop those non-pharmaceutical interventions and everybody's out and around, if that were the reason, you would expect to see at some point a decrease in cases.
I will say that I feel like we have seen, and I'm sorry I didn't include it, a decrease in cases. There's sort of a cluster, and some of that may be reporting bias. Yes. But at the same time, I do feel like we've seen sort of clusters of them, and it in some ways may trigger, or it wouldn't surprise me if it follows along with kind of the cluster that the trend that we're seeing with adenovirus 41 infection overall in stool and gastroenteritis. And we did see kind of a cluster in the winter, which is pretty common, and then it sort of trailed off. And then we had a couple more cases in the summer. We had one at our institution and one in the neighboring institution around the same time. So, you know, we're still seeing some clustering in time, but it's hard to say how much that truly means. But.
Okay, well, we are right at 5 o'clock, or 2 minutes before 5 o'clock. So thank you very much. This was very enlightening about these cases and relates to pandemic diseases, that this is how you go about investigating when you see unusual cases. And I hope that we will see you all on November 9th at 4 o'clock for Dr. Minter's talk on her experiences in Fort Bend County at the health department. So thank you all very much.
Thank you.
Thank you.